Welcome everyone to the 5th Meet the Finalists webinar. I'm Alison Dunn, Joint Managing Director of Chamberlain Dunn, the organisers and creators of the Advancing Healthcare Awards for allied health professionals, healthcare scientists and those who work alongside them. For the past 15 years, these UK-wide awards have been highlighting the often overlooked contribution that these health professionals make to prevention, diagnosis, treatment, recovery and rehab. Northern Ireland over the years have been great supporters, and you've had plenty of winners in that time. It's a fine tradition. Well, we should by now have had our party to have celebrated the winners, but it's been moved, as you know, to the 16th of October, and it's gone virtual. So there'll be no hugs and kisses this time, which obviously is very upsetting for me. But I think it'll be a good hour or so, so do join us, and it'll be a lot of fun. It seems absolutely ages since that judging day in London in February, but the gap has enabled us to spend a little bit more time to find out about the work of our finalists, what the COVID months have meant to them, and how the world now looks for their projects. And the gap has also allowed us to celebrate and recognise the incredible work that allied health professionals and healthcare scientists have done during the COVID crisis. Our esteemed gallery has got, well, I suppose it's now 200 nominations of teams and individuals who have risen to the COVID challenge, often in unfamiliar settings and in unlikely roles. Have a look at it. It's up on our website, the esteemed gallery. You'll find it an amazing experience. And there's a good number from Northern Ireland, so well done. Well, we will get going. Honestly, we'll get going. But I just want to mention one more spin-off from this year's Allied Advancing Healthcare Awards, and that is the publication that we have launched called Making Health and Social Care Greener. It's a compilation of ideas and suggestions from many of the entrants to the awards in response to DEFRA's Year of Green Action. It is, we also announced the winners in there actually. They've had the little sneak preview, they know their winners, but they will get their moment in the limelight at the awards ceremony. It's free to download on our website. Have a look at it because there may be some ideas and suggestions that make sense for you in your own workplace. Well, today we're going to be hearing from the finalists of the Northern Ireland Award for Maximising Resources for Success, where we recognise the crucial role of AHPs in AHP leadership in transforming services. We're delighted that Jenny Keane, Chief Allied Health Professionals for Northern Ireland, is chairing and leading the discussion, so we're in very, very good hands. So Jenny, over to you.
Thank you very much, Alison. I managed there to not have to be told to unmute, which if nothing else is an achievement in this virtual world. But good afternoon, everybody, and you're all very welcome here, where we will be just shortly, in a couple of minutes, hearing from our 3 Northern Ireland finalists in the 2020 UK AHA Awards. These national awards have been a really great platform to showcase and indeed to benchmark the exceptional service redesign that these AHP leaders have led within their own trust areas and within their own services. I'm particularly impressed that the projects which began over a year ago now are projects which can and are contributing to our reform and restructure post-COVID. So I'm really proud of the 3 finalists and their presentations, and I'll start without further ado and begin to introduce our finalists. So first up this afternoon, I'm really pleased to say we have got Carolyn Greer, and Carolyn is a speech and language therapist from the Southeastern Health and Social Care Trust. Welcome.
Good afternoon. Thank you for this opportunity to tell you a little bit about our shortlisted project, the Speech Language Therapy and Ear, Nose and Throat parallel clinic, which we run here in the Southeastern Health and Social Care Trust in Northern Ireland. I'm a specialist speech language therapist working at advanced practitioner level. I work with patients who have voice and throat conditions. These can be functional and organic in nature. I thought what I would do is give you a bit of a background to this project and just to explain why we produce this new service, and then talk a little bit about what the service looks like and what we've done so far, and indeed our challenges in recent times during lockdown. Background is very much linked in with the interdependent relationship between ENT and SLT. The ENT doctor has relied on the SLT in the past to manage the condition they diagnose, and of course SLTs have relied on the doctor to make the diagnosis from examination. At best, in the past, we would have had some joint assessment sessions and some review sessions with the ENT consultants. Some trusts are doing that more regularly, but they're always ENT consultant led, and never before have they been speech and language therapy led clinics. The reason that it came about was that I had been across to a conference in England, the British Oncological Association conference back in 2016, and was inspired by the brilliant work going on over there with different clinics being run between ENT and SLT, but the SLT-led parallel clinic just made sense. And when I came back thinking about the possibility of being able to set this up, it was quite an opportune time, because ENT had been one of the chosen specialisms for the transformation scheme. At that time, it had a 2.5-year wait for routine assessment, and it just seemed like the right time to come together across the two teams, across two directorates, to see if we could make a difference. And so the clinic is benchmarked against best practice for SLTs for these conditions of the voice and throat, as in keeping with our own professional body guidelines. So I went about putting together a proposal, building some will for the idea, and I also needed training in the examination of the larynx, which is the nasoendoscopic evaluation of the larynx, where a scope is passed through the nostril to have a look at the larynx and examine the vocal function. Excuse me. So what have we done so far? So the clinic started in January 2019, 2 clinics a week. Previously, when the doctor had seen the patient, they would have referred into SLT, and the patient would have waited several months for their initial advice. But now what happens is that the clinic runs alongside the doctor's clinic, and it is led by the advanced practitioner speech and language therapist. And it essentially is a one-stop service. Majority of the patients are coming in, getting assessed, getting their diagnosis, and then the right advice strategies and management is given to them on that same day. So what does it look like? Patients are triaged in at the point of referral by the ENT consultant based on some set criteria, which we've agreed. The SLT sees the patient on assessment day in place of the doctor. Full examination is carried out, which includes the passing of the scope to look at the larynx. During that examination, we take both film footage and photographic images with some excellent equipment that we have purchased. And that the photographs and the video imagery is then shared with the consultant, and the doctor and therapist make a diagnosis together, and agree a diagnosis, and then the therapist speaks with the patient and provides initial advice, strategies, how to manage their condition, and sets them up for recovery from day one. There are many benefits to this service. Over the 14 months that we were running, we agreed 100% on the diagnosis of all the patients. 97% of those seen came off the ENT waiting list without needing to see an ENT doctor. 71% no longer required the follow-up service from speech and language therapy. And we've given back 100 hours to the consultants to do their work with more complex cases. We've reduced the waiting time by 80%. And we feel overall so much more efficient service. It's a more sustainable service. Patients are not having to come back to the hospital for further visits, for follow-up visits, for reviews. And more benefits are that they get to see the right person at the right time. And overall, it is a safe, well clinically governed service that offers best practice for the specific conditions of the voice and throat. And so, as I say, it begins the journey of recovery from assessment day instead of waiting all those months for input. We had many challenges during COVID. One of the main challenges, of course, was that the main procedure, the nasoendoscopic evaluation and passing of the scope, is a potential aerosol generated procedure. And so the service was stood down alongside all of the routine ENT clinics for those months. As we waited for guidelines as to what to do next. And when the guidelines came in, we had a lot of challenges. We've had to look for accommodation with the correct air exchange and air ventilation to carry out the procedure. And so there's been a lot of discussion with the ENT as regards patients in the meantime, what advice we can give them remotely. And so we have done that, and we have safeguarded and governed that clinically by saying that we can bring these patients back in to scope them as we feel necessary into the parallel clinic, which is another benefit of having it there. The core voice service that I run, we are also been running remote clinics using the Zoom platform and telephone consultations as well. So we think we're almost there. We've got our accommodation sorted. We need to look at support for that clinic, and we would hope to be up and running as soon as possible. So as well as restarting the clinic and getting it up and running as safe as we can, we're obviously thinking outside the box with that. We're thinking what other way can we be running it so that we're ensuring that we continue to clinically govern well, and that might make the clinic look slightly different for a while, and that might just have to be the way it is until we get working back into our routine, using our rooms again. Once we have the clinic up and running, I'm keen to promote the clinic again. I'm keen to work toward increasing awareness, and that was something that I was about to embark on with regional presentations before COVID happened. So that's on the agenda. I would also be very keen to involve our service users at looking at what next. There's so much we can be doing with this clinic. We're only at the tip of the iceberg, really, with the type of services we can offer. We could be seeing review patients, red flag patients. We could be doing more in-depth swallow assessments with the same procedure that we carry out there. So there's a lot of ways we can go with this clinic, and we need our stakeholders involved with developing that going forward. And money-wise, of course, we need to think about benefits of money-saving benefits for this service, and certainly even just looking at the difference in salary between the SLT running a clinic and the consultant. We're already looking at a projected saving over 5 years of almost $500,000. And so, although of course money isn't anywhere near as important as the improvement in this quality of his care, we do need to think about that as well, and it's a great benefit. But ultimately, this is about quality of care, and it's about providing a more efficient, more sustainable service that is improving efficiency for the patient. We feel that this really is transformation at the core, because we're maximising the strengths of the SLT, working at advanced practitioner level, in keeping with the advanced practitioner framework here in Northern Ireland. And we're maximising the strengths and skills of the consultant by giving them the time to do the work they need to do, as well as improving the service for the patient. So overall, we think we're delighted with how the project has gone so far. There's a way to go. We're excited about that in the future, and looking forward to seeing what happens next. Thank you very much for listening.
Thank you very much, Carolyn. That's been a very, very inspiring presentation. And I suppose before we move on, the thing which immediately comes to my mind, particularly having listened to all of the benefits that you've outlined for in this clinic, and I think it really sits very well within the outpatient reform agenda that we currently have. Do you think that there's potential for this model of service to be extended into other areas, or can you see the learning of it extending further?
Thanks, Jenny. Yes, I mean, absolutely. Even since we have started the clinic or planned the clinic, we are seeing different diverse caseload coming into it. All under the ENT umbrella, but it's not just voice conditions, it's upper airway disorders, and looking at anxiety related conditions, and those type of conditions are, we're seeing a fast increase in those conditions coming through ENT. So actually the caseload that we're able to get to now is wider. And that's really just happened in the last few years, and that's the case across ENT SLTs across the UK. We're noticing that difference, and so those are patients that are coming from respiratory services as well, with chronic coughs, or coming in GP referrals for globus sensation, for example, of feeling a lump in the throat. So there's lots. It's not just your voice patients coming in to access this clinic, but the thing about the parallel clinic is that we would hope to be, as I was saying earlier there, hope to be able to expand the patient group as well, not just with the diagnosis, but also the urgency of the patient being seen. So we have just recently there negotiated taking some red flag patients into the clinic to manage during this return restart of clinics within ENT, to help manage with that. And so red flag patients, review list patients, will be able to expand across all of that area, hopefully. And actually, that's within trust. But really, if we were allowed to sort of unclip our wings and fly, this project can take off regionally. We are the first in Northern Ireland with this type of clinic. It is run as almost like the norm across the water, and is seen by our own professional body as an essential skill to be able to assess and evaluate the larynx when you're working with voice and throat conditions. And so we're lagging behind a little bit with that. And, you know, speech and language therapists are well rehearsed in how we use scoping. Many therapists are working with FEES, the endoscopic evaluation of swallowing, which is a similar procedure in passing the scope. So it seems like a natural progression to move that into ENT, and we have the backing of our own professional body with that, with a very strong clinical governance competency framework. So with the right collaboration, and it is a partnership between SLT and ENT, they have to work together. With the right collaboration, there's every opportunity to expand this, even within our own trust and beyond it.
Okay, thank you very much, Carolyn. I think, yes, that is what I had picked up from your presentation, that yes, there is great potential for this as a model to extend both in the patients that it sees, and the conditions, but also potential for regional spread. So no, well done. And I'm taking a very quick look at the comments coming in on the chat box, and again, everybody's commenting very similarly. Great potential, ticking all the right boxes. So well done. And before I move on to the next presentation, I'm just going to give a reminder to those of us that are on the call. Please do use the chat function. We will record, we will have a record of all of your comments, and we'll utilize that at the end. And if any of the questions that don't get answered, we will endeavour to get an answer back to you for those. So please feel free to pop whatever you would like into the chat box. So then we will move on to our second presentation, and our second presentation is a duo from the Belfast Health and Social Care Trust. Always great to see a joint presentation. And so we're going to speak to Carly and Cheryl. Carly Brown, a therapeutic radiographer, and Cheryl Mackin, a specialist dietitian from the Cancer Centre in the Belfast Trust. Looking forward to your presentation, girls.
Thank you. We just want to share a project with you now in a few words. Hopefully you will find it interesting, and feel free to pop any questions in the chat box at the end. Thank you. So this is an overview of our FeedNG service, which is an outpatient nasogastric feeding service for head and neck cancer patients within the Northern Ireland Cancer Centre in Belfast. This project really came about on the back of patient feedback because many patients who undergo treatment for head and neck cancer require alternative feeding due to the increasing impact of treatment toxicities on their nutritional intake. And historically, this meant that patients were required to be admitted for the duration that supportive feeding was needed. And patients were therefore very reluctant for an NG placement because they were aware that it was going to result in many weeks in hospital where they would become increasingly frustrated, where they were missing life events, and they just wanted to remain at home. But this actually ended up being quite detrimental to the patients because when they did need admission, they were usually over 10% of body weight loss. They were in a malnourished state, which usually meant a more severe toxicity profile, which was harder to get on top of, and that meant coming into hospital resulted in longer stays due to more complex symptom management. So over a 6-month period back in 2018, we calculated that a mean number of days admission for a head and neck cancer patient on feeding was 33 days. It's very well documented in literature the importance of nutrition and the impact that malnutrition in head and neck cancer has, in that there's lots of associated morbidities with it, including increased risk of infection, delayed wound healing, depression, poor quality of life, and a reduced response to chemotherapy and radiotherapy treatments. And so malnutrition generally resulting in greater toxicity, resulting in a longer recovery period. So there are several common acute toxicities that exist during a course of treatment for head and neck cancer, with oral mucositis probably being the most common debilitating complication of cancer treatments, particularly with chemotherapy and radiation. And that can lead to several problems. Primary one being pain, nutritional problems as a result of the inability to eat, and increased risk of infection due to the open sores that are in the mucosa. Nausea and vomiting are also very common, but these toxicities can generally be quite well controlled with adequate analgesia, with oral mucosal barriers, and with antifungal medications. Traditionally, a head and neck cancer diagnosis was most prevalent among those who were between the ages of 60 and 75 years of age and who had a history of alcohol or smoking excess. However, over the last decade, head and neck cancer incidence rates have increased by approximately 24% in the UK. And this incidence rate increase is closely linked with the increasing rate of HPV-related oropharyngeal cancers, of which 60 to 80% are HPV positive. So these patients are in a younger age bracket, and they generally would be of a demographic of non-smoking, non-drinking. So with this younger patient demographic and HPV-driven cancers, the toxicity profile remains the same, but with the addition of early onset poor taste and thick secretions, which are difficult to manage pharmacologically and therefore resulting in earlier onset of a reduced oral intake. So we then anticipated that earlier introduction of enteral nutrition, primarily in the form of NG feeding, would lessen the weight loss in the short term, would minimise acute toxicities attained, would reduce unplanned hospital admissions and improve recovery after treatment. So we identified that a number of these patients could be considered for commencement of nasogastric feeding as an outpatient. And so we established a multi-professional team in November of 2018 with various stages of project development taking place. So where we were liaising with stakeholders, we developed protocols, we set up focus groups with patients, there was staff training, raising awareness within our hospital and establishing a new weekly multidisciplinary meeting. Historically, each profession was working quite uni-professionally, and while at the time that was fine, we began to recognise that transformation to a more multi-professional approach was going to be required, where the patient was centre and where uni-professional silos would be no more. And with obviously the service users playing a key part at every stage in that development. And this is just a little picture of our first celebration event with our patients to mark 100 days where we had given days back to them to spend at home as opposed to a hospital admission. So why did we submit to this category of maximising resources? Well, this service development initiative has resulted in very significant savings for our limited resources of staff, of beds, time and finance, without requiring any additional resources from what we already had in place. But most importantly, we have improved the patient experience. And 1 year after establishing our project, we calculated more than 1,000 days were given back to patients at a time whenever they needed the support of families at home. And our patient focus groups from the very outset highlighted that this was the most important factor to them. From a service perspective, we had fewer oncology outliers, as these patients could now occupy what previously would have been a head and neck cancer patient's bed, which meant more patients were able to have access to specialist care. And from a financial perspective, with 1,028 bed days saved, produced a gross saving of more than £609,000 over that year. So by working together and sharing interprofessional information, we were able to establish an alternative management strategy for these patients, while also recognising the potential impact of cancer services on cancer services as a whole. With the increasing HPV patient cohort, we recognised that the earlier intervention with enteral feeding was going to have a further stretching on inpatient services significantly in bed pressures due to admissions for feeding, requiring more chest x-rays and increased cost to the trust. So with these improvements to the pathway and the various elements that it encompasses, we believe that it really is an excellent example of our trust's values. And we believe that we now have the right people in the right place at the right time. And then, unfortunately, COVID happened. And this meant that our outpatient NG feeding service had to be suspended in light of patient safety. Primarily because NG placement is an aerosol generating procedure and the patients would be required to be in an outpatient area for extended times daily. And if there was any troubleshooting issues post-placement of the tube, for example, if the tube's dislodged, it just meant that patients and staff would be placed at increased risk because there would be increased footfall within the hospital to have the tubes replaced, and that would require patients entering a hospital in a very unscheduled manner. And that in present times is unsafe. But it is important to highlight at present that we do still feed our patients, we don't starve them, but we just do that as an inpatient. So although NG feeding and Feed NG project has been temporarily suspended, we do continue to work very closely as a multi-professional team, and the setup of this service has actually led to a more cohesive multidisciplinary approach generally, and working very collaboratively with the patient always at the centre. So post-COVID, we will need to re-establish the outpatient service at the right time. But to date, this is just a summary of how we have maximised our current resources. But however, to expand the service further and maximise the benefits to the Trust, we would require some future investment in staffing and in enhancing the service user environment. We would plan to set up 6 monthly evaluation patient feedback questionnaires to determine user experience and highlight any potential improvements or highlight negatives. We'd also plan to audit the pathway annually, and again that would highlight any areas of good practice for the future. And on the whole, we believe we've generated a service model that is very transferable to other departments, particularly radiotherapy departments where patients attend daily for treatment. And we've actually had some interest already coming from other centres.
Thank you very much, Carly and Cheryl, for your presentation. Even the pictures on the second or third slide, which are always quite harrowing to actually see the distress that these patients go under to get a curative course of treatment. Carly and Cheryl, I mean, I think for me, the thing that stood out for me is that this is what I would call a prehabilitation service. So I know we are very focused in this post-COVID or this COVID environment of rehabilitation, but what you've described here really is a prehabilitation service about actually ensuring patients are well enough to be able to undergo their treatment and to stay well during their treatment. Do you think there's any learning of how you can adapt that prehabilitation approach to other areas, either within cancer or wider across the system?
Absolutely, yeah, thanks Jenny. I think this is a prime example that could be very easily transferred to really any other cancer centre because they will have a dedicated radiotherapy service where patients do attend on a daily basis. And so with that, it's a key opportunity to provide a tight multidisciplinary team who can coordinate that approach and that care. We did find that the secret to this project's success was the team approach and having everyone on board to do their bit at the right time. It was never going to work uni-professionally. So this has proved that multidisciplinary working really does pay off for the patients. So any centre across the UK, and in fact across the world, who provides radiotherapy could adapt this process. And even outside of oncology, I think any disease process where patients require NG feeding, the ultimate aim is to keep patients at home if you can. So I think, again, with a little bit of adaptation to any service, it could quite easily be transferred, absolutely. Yeah.
Absolutely. I suppose we're very lucky in radiotherapy, and we maybe take it for granted that although we are an outpatient service, because we see our patients every day, it means we have that constant interaction to troubleshoot any issues with NG tube. So that might be a challenge for other disease processes who require use of NG. Certainly within Northern Ireland, there are some regions and some trusts that are creating positions for NG specialists within the community to provide that feeding service and to provide that community assistance and support. So certainly within the trusts where that is already established, there is more scope to run this for other outpatient services other than just the radiotherapy at this point.
Okay, thank you very much. I think anything that optimizes patient performance prior to an intervention, and particularly that allows patients to stay at home with the least amount of time in hospital, has to be commended. So well done. And now we go to our final finalist, if that's okay to say, our final finalist. So I would like now to ask Suzanne Kennedy to give us her presentation. Suzanne's a physiotherapist from the Northern Health and Social Care Trust.
Hi, thank you, Jenny, for that introduction. So yes, I'm Suzanne Kennedy, physio in the Northern Trust, and I'm representing the Orthopaedic Assessment Service here today. So our project is called A Good Call for Back Pain, and I'll just give you a little bit of background for that. So historically in Northern Ireland, we have had very long orthopaedic waiting times, and in 2019 there was over a 4-year wait to see a spinal consultant, with around 10,000 patients on the waiting list, with a fifth of those being referred from the Northern Trust. So research has showed that a large volume of referrals to secondary care are inappropriate, and most of these patients can be managed in primary care. And also the conversion rate in spinal clinics for surgery was very low. So that was really the driving factor to have a look at these patients. So we had extensive engagement between the Regional Orthopaedic Centre in Musgrave and the 5 healthcare trusts, and we looked at various strategies to try and improve the waiting list for spinal patients. So the backlog had to be addressed, and one of the strategies that we discussed was telephone assessment clinics, and that's what we're going to look at today. So in the Northern Trust, we agreed to take back all our referrals that were made by the Northern Trust from all sources, and that included the ones actually made from our own service. So we took back all the longest waiters, dated back to 2015. And we were looking to see whether these patients needed to remain on the spinal waiting list. So the aim of the clinic was really to reduce the number of inappropriate referrals on the waiting list, improve the times for those that did need to see the spinal consultant, and really manage these patients appropriately, because as I said, most spinal patients don't actually require surgery. So we initially started with about 30 or 40 referrals, and we did a pilot clinic to ensure that it was feasible and to iron out any issues. And we ended up taking around 1,300 referrals, which was the ones from 2015 to 2017, which was quite a lot actually. And there was preparation time before we rolled out the clinics. We had to engage with our IT department to get new IT codes set up. We had to develop letters for the patients and the GPs, and the team were involved in getting assessment sheets developed to ensure comprehensive assessment and safety netting was incorporated into the assessment. And then the clinics were set up on the IT system. The patients received a telephone appointment booking letter. They had to be available 15 minutes either side of their allocated appointment time to allow for runover, and the appointments were scheduled for 15 minutes. So we ran these clinics simultaneously for some peer support. We had access to as much information as we could from the referral, from the electronic databases, NIECR and IPACS. Patients were assessed regarding current symptoms, previous diagnostics if they had any, and they were checked for red flag and cord symptoms. So the patient and the GP were clearly informed of the outcome of the telephone assessment, and that if they were discharged from the spinal waiting list. If the patient did require spinal surgery, they were reinstated back at their original position on the waiting list, so there was no detriment, the patients weren't disadvantaged. Challenges, well, the very obvious one was we were contacting these people by telephone, so they needed a telephone number. So that was where our admin support was vital. For the clinicians, the main challenge was the talkers on the phone, so it was getting them off the phone. Language, if English wasn't their first language, that was obviously more difficult. And it was much easier to manage these patients if they'd had previous investigations. And then because of the length of time they were waiting, we had a lot of duplicate referrals. So again, our admin were heavily involved in helping us with that. So the outcomes from our 1,300 referrals, nearly half were discharged on that first telephone call, with about a fifth being referred on to other services. 24% we booked for a face-to-face review, but half of those required an interpreter. The others were patients that requested a face-to-face review, and because they'd been waiting for such a long period of time, we thought that was a reasonable request, and we made capacity to be able to see those patients. The others were ones that we were possibly concerned about and felt needed an objective examination. So of the face-to-face ones that we saw, again, most of them were discharged with a few referred on to either other services or for diagnostics. So the outcomes were actually much better than we had ever anticipated, with the majority of patients being managed within our service and only 3% being returned to the spinal waiting list. So that meant for the Northern Trust patients, their waiting time was reduced by 2 years. And this initiative, in combination with the others, reduced the overall number of patients on that waiting list from 10,000 down to 2,500 at that time. I think that has probably increased now, unfortunately. However, one of the advantages was the patient satisfaction. It was quite funny because at the very start, one of the reservations the staff had about this project was that we all presumed that we would just get an earful down the phone because these patients have been waiting for such a long period of time. However, interestingly, most of them were actually very grateful for the call because they thought they'd been forgotten about. It was terrific learning for the clinicians because they could reflect on their decision making, particularly on the referrals that they'd actually made up themselves. It was very effective use of clinical time because we saw twice the number of patients that would have been assessed face-to-face, and very cost effective as patients were assessed by the physio instead of consultant. And then COVID hit. None of us expected a global pandemic. So the impact has been enormous on healthcare, and it has changed the way we all live and work. So like physio, like most services, face-to-face consultations pretty much stopped, and we've all moved to remote working has become sort of the new normal. So we had our processes in place, and the staff had experience of the teleassessing. So we were able to scale this up rapidly. And I think in the future, remote consultations will remain, whether that's by telephone or by video. There's certainly a cohort of patients that can be managed remotely very effectively and safely. And some patients prefer the convenience of the telephone call, rather than having to come in to a healthcare setting. So these skills were very transferable to all services. So this is a green award, and we have to consider the environment, and we all have to do our bits. And remote consultations certainly do that. They reduce the carbon footprint. You don't have patients traveling for their appointments, and there's a significant reduction in the use of paper. So it's a very sustainable model of care, and I think that's one that's going to be with us for quite some time. So I would just like to thank everybody that's taken the time to listen to us today. and particularly to my team, the clinical and admin staff, for this good piece of work, and to the Advancing Healthcare Awards for recognising their work. Thank you.
Thank you very much, Suzanne. It's always difficult to wait till the end to come on at that point, so well done, well done. One reflection, I think, that before I even ask you a question, I think it's commendable that you reflect on your own professional practice and hold that mirror up to your own, you know, the inappropriate referrals even from within your own profession. And I think that is what makes us professional across all of our workforce. So it's great to see that being just put in there as just, that's just what you ordinarily do in your day-to-day practice. So really nice to hear that. But I suppose what I'm really thinking, having listened, Suzanne, is, you know, absolutely fabulous impact and great benefits. Do you think you could translate what you have learnt and achieved in the spinal service in any other service? And from a non-physio, I can say other parts of the body without it sounding too unclinical, but is there scope for that?
Yes, absolutely, Jenny. I think with regards to the orthopaedic conditions, I think if we build up the relationships with the consultants, there has to be a trust there that they're happy to pass those referrals back. But I think AHPs have a huge amount to offer. And like the other projects, you know, where we were working alongside the consultants or instead of the consultants. So yes, they definitely could be rolled out to all body parts. And then the telephone assessments have just like taken off, and I think has become, I think every service is carrying those out now. So it was good that we were ahead of the time.
Okay.
But just on your comment, Jenny, about the reflecting. Initially, whenever we started the project, the staff weren't keen to take their own referrals back, but it was too difficult logistically to sort those out. And it actually worked out. That was where the best learning was. So it was well worth it.
Yeah, thank you, Suzanne. I did pick that up and think that that's great to actually see that reflective circle within the case study. So we've heard from all three of our finalists, and I have to say, I mean, I know there are some of the other system leaders, HP leaders on the call this afternoon, so I know that it isn't just me, and I'm sure it's your trusts as well that are extremely proud that the finalists that we have on this award are as strong as what they are. I mean, you're all exemplar, both to your professions and to your trusts. And you know, what's particularly impressive is that these projects are now so relevant today, given everything that we've went through over the last 6 to 8 months, and they're relevant to the challenge that we know is ahead of us for the next year, 2 years. And I think that really is a tribute to both yourselves and your trusts that these projects did get underway. I'm conscious we have a little bit of time before we have ended, and I'm going to look at either Alison or maybe Will. Do I have time to possibly pose an additional question to the finalists? Or are
Yes,
we?
you do. Yes.
Okay.
I will say
and
yes.
they all smile. Carolyn, I'm going to go back to you, and I'm going to just ask you very briefly, the staff, in terms of, you know, the speech and language therapists in your team, is this a more rewarding way for them to work? Is it something which you get feedback from your team that, whether it's just these speech and language therapists or perhaps others wider in your team, do they enjoy it? And you're on mute. I was looking forward to seeing that all afternoon.
I'm good to go. Yes, the answer is yes. You know, my background is in multidisciplinary team working, and I feel it you know, it fits so perfectly with this patient group. And as I was saying in the presentation, it is about that strong collaborative relationship between the ENT doctor and the therapist, and that we kind of have this interdependent relationship. You know, we need the clinical governance of ENT, but also they need us for managing the condition. And so that's a lovely way to work. It's extremely satisfying. You have two sets of eyes looking at one condition, coming at it from different perspectives. So both from a medical diagnostic viewpoint and then from a rehabilitative viewpoint. And so it just makes complete sense. But yeah, I think as well, what's interesting in it was I feel like, you know, I've got so much out of it in terms of learning, of course, but what you can see as time goes on is the learning within ENT generally, and even in referrals that we get, you know, because SLT are present in the ENT department, then there is a very subtle education and increase in awareness of the condition and how you can manage it. And I think that most probably helps with their own professional and clinical development as well within ENT. So yes, it's a really enjoyable way to work. You get a great buzz from being able to come up with a solution for somebody. Someone leaves the clinic with a proactive plan of how to start getting better and getting back into life again and being included in life when they weren't, when they had no voice before, or their condition was so debilitating that it was affecting their work, you know, their family life, etc. So yeah, it's an extremely satisfying way to work, and every day you learn something new, which is terrific.
Okay, thank you, Carolyn. That's good to hear, because I think for it to be sustainable, yes, the staff, more than just, you know, staff need to be able to enjoy it and it be sustainable from that perspective as well. Carly and Cheryl, I mean, I've looked in the comments here, and a lot of the comments are saying they absolutely love the ethos of giving patient back days, you know, not framing your project in the context of saving beds, but it's actually the giving back piece, which makes me want to ask you, you know, this must get very positive feedback from your patients and from their relatives. You know, would you like to just give us a sense of what that's like and what you hear from your service users?
Yeah, so all of our patients, I suppose initially when we started to implement this project, we weren't really sure how the patients were going to buy into it, because it gives them ownership over their care, which sounds great, but it's a bit daunting because it's not only the placement of the NG tube, we then have to train them in how to use it, how to test pH levels, how to feed, and how to troubleshoot the issues and not panic, and all of those sorts of things. So, and when they take that equipment home, it in some ways can medicalise their home. So we weren't really initially sure. So we did all of our meetings with patients and carers from the outset to get their feedback. And again, there was mixed feelings. But when we implemented the project, suddenly all of our patients really bought into it. They felt really confident with the training that was supplied. So there were none of our patients that actually went home with an NG in that felt in any way overwhelmed during a time when the treatment itself can be very onerous and very time consuming with the daily treatments. We didn't want them to feel like actually when they went home that treatment was continuing and very onerous. They very much seen the side of it gave them some normality. They were able to be at home to help with the school runs. They were able to help with the making the dinner. And although they might not have been sitting down with their family for dinner, they were able to be present. And it was just the being present at home and having that support that meant more to them than really any additional tasks that we were kind of giving them to fulfill.
Yeah, I think one example that sticks out in my mind is that there was one patient in particular who was required to remain in hospital for a significant number of weeks after treatment. He was actually part of the initial patient focus groups, and his main thing was that he needed to be at home for his family, and his children were going through major life events, and he just stuck in hospital, and this was the only reason he was in hospital, was to continue with this NG feeding. And at that point there was no option to send him home with the feeding. So for him, he is a key example of now a patient in his position can go home and can experience those life events with family and continue their recovery in the comfort of their own home. That for patients is number one on their agenda, you know. So it's lovely to be a part of that and to be able to help provide that. It's huge.
Thank you, Carly and Cheryl. Yeah, I think that's come through very, very clearly. And I think that I'm going to use the right words, giving patients back days. It is something which we should instill in all of our improvement work. Suzanne, I'm not going to go back to the staff being content piece, because you've explained that well to me. I'm just wondering, when I'm listening to the number of patients that you have prevented having surgery, I'm just wondering, you must get a sense of relief from patients and feedback from patients that are telling you just how relieved and positive they find your service. And do you want to have just a wee minute to tell us a little bit about that?
Yeah, well, particularly with spinal patients, a lot of it was like reassuring those patients that what they were doing was correct. And it was really because they had been waiting for such a long period of time. A lot of them had learned to live with their pain, and it was just reassuring them that really that was their best option, and that surgery wasn't going to cure their pain. So in a way, that time frame helped us to manage them, and so a lot of it was reassuring and advising them to exercise, and a lot of them had taken ownership themselves and were quite proud, and a few had settled. Very often people learn, people's condition settles, and it was about encouraging them to exercise. And some of the longer consultations it was quite funny, because although people's condition had settled, they still wanted to tell you how bad they actually were. So you had to listen to it all, that's part of managing them, of them feeling listened to and engaging, with what you're telling them. And it's really about getting them moving. And if you can tell them, yes, that's, you're doing the right thing and you've managed this very well, they bought into that. And really that is the key thing for spinal pain, is exercise, So we were talking about other body parts. So the spine lent itself very well to this initiative because, surgery isn't a good option. So the conversion rate's very low. Other body parts may be different because, there's more possible surgical options out there for them. So it'll not be the same with everything, but yeah, it was very rewarding actually. And the staff actually, from being very apprehensive at the start of the project, once we got going and got into it, they all got, a lot of satisfaction out of it. So that was good.
Okay, thank you, Suzanne. Thank you. And I suppose at this point, I hope you're all, looking forward to the actual award ceremony, which will be virtual, but it will be on the 16th of October for us to hear which of these 3 projects and which of these 3 teams actually is considered to be the overall winner. It might seem flippant of me to say, but when I'm listening to the 3 of you today, and I'm sure the rest of the people on the audience, you're all winners. You have all really, really articulated and described 3 excellent projects. And I think, like I've said a number of times now, the fact that these are very relevant to today's transformation and rebuild agendas really demonstrates how good they actually are. So I know there's a number of you on the call, and I know you have other colleagues, and I'm really looking forward to being able to celebrate the actual event with you all on the 16th. And again, thank you all for the effort that you've put in. I was extremely proud when you were final, when you presented your awards back in, wasn't it March? It was in March, in London. I was newly in post, and to be sitting with peers and representations from some of the other institutions across the United Kingdom, and to have had 3 finalists of this stature really was a real pleasure. So congratulations. I mean, you really have done both your profession and AHP is wider, and your trust's extremely proud. So well done. I'm going to just ask Ali now if she would like a few words before we finish up.
Thanks, Jenny. I'm just absolutely bowled over by the compliments that have been flooding the chat box. I've never known anything like it. So really, really well done. Amazing. It's been fantastic to see that as the hours gone by. And thank you, Jenny, for your fantastic chairing. It really, really made a fantastic afternoon, and for your support, of course, for the awards. Thank you, Carolyn, Cheryl, Carlene, and Suzanne. That was really brilliantly done. These are 3 amazing projects that, as we've heard, are really highly transferable, outside Northern Ireland, right across the UK. And I think you're going to be in great demand to share your work over the coming months. And it's great to see in the list of participants that there are people from other sectors, which is a great sign that the contribution of AHPs to transforming healthcare is beginning to be understood. So that was another wonderful thing about this afternoon's webinar. It's part of a series. This one will be up on the website shortly, and the previous ones are already there. So do share that with colleagues if they want to catch up. This one will be up in the next couple of days. We've been reminded several times about the date of the celebration, 16th of October. Bookings are going to be open soon, so get signed up and tell your colleagues. It's all free and lots of fun. And finally, thank you, Rachel, Joy and Ellie, our in-house team, for ensuring that all went smoothly organisationally and technically. You're so valuable. It's been brilliant. So thank you, everybody, and have a great rest of the day. Bye.